Thank you, Dr. Shudi. And let's start with this online meeting of the Breast and Endocrine Society of Western UP, that is the Brendos. The topic for today's meeting is understanding the hyperparathyroidism in chronic renal failure. And I'll just introduce our guest faculty today. And we're really honored to have with us Dr. Anand Mishra, who is Professor and Head Department of Endocrine Surgery, King George Medical College, University, Lucknow. He is a thyroid and breast cancer specialist surgeon, and he is an MBBS from KG Medical College, 1988 batch. He did his MS in general surgery from GSVM Medical College and passed out in 1997. Then he has a PDCC in endocrine and breast surgery from Sanjay Gandhi, and he also has a master's in endocrine and breast surgery from Sanjay Gandhi. Then he also has an MPH from University of East Anglia, UK, and FICS and FACS. And he has numerous coveted presentations and scholarships to his name, and a number of international and national publications, and many coveted memberships also. I welcome Dr. Anand Mishra, and our next guest faculty is Dr. Gyan Chand, who is a professor of endocrine surgery, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Raebareli Road, Lucknow, and he is an MS from King George Medical College, Lucknow, 2000 batch, and he's an MBBS from BRD Medical College, Gorakhpur, 1996 batch, and he did his PGD HHM from IGNOU, New Delhi, and PhD from Lucknow University. He has many honorary fellowships, including Fellowship of International College of Laparoscopic Surgeons, Fellowship of International College of Surgeons, then MRCS, FCYCC, FMES, FAIS, and he has a vast clinical and teaching experience starting 1990s. And he has an international fellowship in robotic surgery and was a part of our international fellowship program. And he has numerous coveted awards and fellowships to his name, like Dr. W.R. Gazdar Memorial Oration, Dr. S.P. Srivastava Oncology Oration, and many others like this. And he has a special training in robotic surgery in breast and endocrine, and he has a vast surgical experience of managing the breast and endocrine gland surgery cases, and he has numerous national and international research publications to his name. And I welcome you, sir, to this meeting. And also we have with us our expert pathologist, Dr. Neha Nigam. I welcome you. She's an associate professor, Department of Pathology, Sanjay Gandhi, Lucknow. And of course, we also have Dr. Sudhi Kamboj with us, who's a consultant and head, Department of Breast and Endocrine Surgery in Newtima Hospital, Meerut. And I also welcome Dr. Chani Jain, who's a consultant pathologist of in Diagnostic Center in Meerut, and Dr. Reena Dhamija, who's a consultant nuclear medicine specialist in Meerut Scan Center, Meerut, and Dr. Meena Bambi, who's a consultant radiologist in healthcare imaging, a very renowned healthcare imaging center of Meerut. So I welcome you all, and with this, I think we start our proceedings. And the topic today is secondary hyperparathyroidism. And we know that hyperparathyroidism, secondary to chronic renal failure, is a condition characterized by inappropriate secretion of parathyroid hormone, which is secondary to a phosphocalcic metabolic disorder. Surgical management represents a very definitive management, a radical treatment of this disease. And the purpose of this activity today is to review and to discuss the interprofessional team involved in the management and diagnosis of such cases. Thank you very much. So till the time, I think, Dr. Sudhi, you are just starting. I think we are really honored to have such knowledgeable speakers with us. So I'll just ask Dr. Gyan Chand that how common is it in your practice to see patients with renal failure who have secondary hyperparathyroidism, and how many of them go on to require surgery for this problem?
Thank you, doctor, for asking this type of very interesting questions, like, because we are working in the referral center, so most of the time the patients usually refer to us. So as in our institute, the renal transplant unit is very well working. So most of the patients go for the renal transplant. So longer duration of dialysis patients, usually it is happen in more patients who are dialysis more than 10 years. So in our practice, it is very less common because majority of the patients who are on the dialysis, they go for renal transplant. But however, we are only few patients we are operating and treating in our department. Although majority of the patients, if they are in our institute, they might be taken care by the nephrologist and by taking care by the endocrine physicians, not by us, because we are referral center. So usually once they find appropriate for the surgical team, then only they refer to us. Otherwise, most
Okay.
of the time they are treated by the endophysicians and nephrologists.
Nephrologist.
Yes.
Dr. Sudhi,
Yes, sir. I am all
you're all
set.
set?
Yes, thank you very much. So
Okay.
should I start?
Let's start. Yeah.
Yeah. Thank you very much for your patience, everyone. And starting with the case, as we know that today we will be discussing, we will try to understand the hyperparathyroidism in chronic renal failure. So this was a 53-year-old male who had recurrent nephrolithiasis and urinary tract infections since 2009. He had bilateral multiple nephrolithotomies because of the same. He had a history of pathological fracture right foot in 2010 and extreme generalized body weakness and he remained like he did not receive any specific treatment except for nephrolithotomies off and on until unless in 2018 when he experienced extreme generalized body weakness and bony pains and associated he has dyspepsia, epigastric pain. Overall, he was not feeling good. Then in 2021, he presented in emergency with complaint of generalized extreme body weakness, body wasting, bony pains, as if like he was about to die. When he first presented to us, we had he presented to a nephrologist basically because of his preliminary investigation showed raised creatinine. So he had a full-fledged workup done, which showed a chronic renal failure, which requires dialysis twice weekly. His family history was non-contributory, and apparently he was non-syndromic. On clinical examination, he had nodular lesions on either side of the trachea, more on the left side compared to the right, but the right side, it was a nodular lesion, but the lower border was not reachable. Along with that, he had multiple bony swellings, more prominent on either side of the chest wall. So those and the middle end of the clavicles, suggestive of some brown bony pseudotumors were there. So his biochemistry revealed chronic anemia. His serum urea and creatinine were raised. Albumin was low. His TSH was suppressed. Okay, and his alkaline phosphatase were raised. Inorganic phosphorus was also raised. Random blood sugar was normal. Calcium was very, very high. It was in the range of 15 to 16 milligram per deciliter, much above than the higher reference normal range, both ionized as well as total. And he also had a IPTH, intact PTH done, which was more than 20 times raised than the upper normal limit. His 25 hydroxy vitamin D was within deficiency or insufficiency range. Other than that, his serum amylase and lipase were also marginally raised. So he had some workup done elsewhere where maybe because of his hypercalcemia, he was worked up for multiple myeloma and his urine Bence-Jones proteins were negative. And he had a significant pyuria, 40 to 50 plus cells in his urine, along with red blood cells also. So because of he had a nodular swellings in the neck, we had some imaging done because of all these nodular lesions in his body. And I request Dr. Annie to describe the images.
Very good afternoon, ma'am, and all the faculty here. So the patient came to our department for ultrasonography where we could find mildly enlarged bilateral lobes of the thyroid gland, and there were well-defined hypoechoic lesions with some cystic areas within. The vascularity of these lesions were not very much, and these lesions were mainly peripherally placed, and they had a well-defined capsule around them. Next slide. So there were some coarse ecotextures with some foci of calcifications, and the heterogeneity of these lesions was much. Mainly, the right gland lesion was more heterogeneous, and left vella was comparatively homogeneous. And the right looked suspicious to us, mildly suspicious to us. However, left was like it appeared to be some benign lesion only. Then further, we did chest X-ray and other skeletal workup for the patient. In the chest X-ray, we can see there were multiple lytic expansile lesions of the ribs on both sides. But still, we expected a CT chest to be done, since the lesion on the left side in the middle zone. We had to rule out whether this is an intraparenchymal lesion or is it the bony lesion only that is appearing, giving this kind of appearance. And otherwise also we can see there is generalized mild reduced density of all the bones, and there is mild scoliosis of the spine towards right side. Next please, ma'am. In this, on the X-ray KUB, we could find multiple calcifications in both the renal region. And otherwise the spine was fine. There was no rugger jersey kind of spine or sclerosis that we could see in the spine. Over in these also we can see these lytic expansile lesions in these lower ribs also. This was a salt and pepper kind of skull where we can see multiple sclerotic and lytic areas diffusely scattered in the skull, and also we can find some missing teeth basically in the jaw. In this, there is very subtle finding that we can see there is subperiosteal resorption along the radial aspect of the second and third fingers in the proximal and middle part, more on the middle phalanx basically. And there are few soft tissue calcifications that we can see in the interphalangeal, intermetacarpal soft tissues. This we were suspecting, if it is a case of hyperparathyroidism, then it can be some kind of calcinosis or soft tissue calcification. That is a commonly associated finding with it. Then the patient came for CT chest for us, where we confirmed that these lytic expansile lesions are from the external ribs only, and no intraparenchymal lesion of the lung was seen. The lungs were per se normal. There was again reduced density of all the bones with mild scoliosis, and interesting finding was also found in the there was amorphous calcification in the soft tissue in the right shoulder joint. Basically, soft tissue calcifications were noted over here. In both the kidneys, mainly on the right side, we could find out calculus and some cortical calcifications as well. And on left side, there was mild hydronephrosis, mild dilatation of the pelvic LACL system that we could see. And on the upper section of the chest, we could see that by both the lobes of thyroid gland are bulky and enlarged, and some dense calcifications are noted in both the lobes.
So I request, with all these images, we then send the patient with biochemical confirmation of hyperparathyroidism and with a nodular lesion, the region of the neck and the parathyroid region. And because this patient had a bilateral lesions and both were looking intrathyroidal, we sent the patient for nuclear medicine imaging. We asked for a MIBI scan. I request Dr. Reena Dhamija to explain the images to us.
Yes, this is technetium system MIBI scan that's showing planar imaging. There are early and delayed images are seen. Early images, you can see there is uptake in the thyroid gland. Along with there is a very high intense uptake, which is seen in the left lobe of thyroid at upper pole. When we see in the delayed images, that thyroid is showing almost complete or almost washout of activity, but this particular part, upper pole of left lobe, that is showing avid uptake, that is persisting. So this is most likely, or I can say confirmatory of parathyroid adenoma in superior parathyroid gland.
So this MIBI
This
scan.
is another, yes, this is technecium MDP bone scan. This is whole body skeleton. You can see planar images anterior and posteriorly. You can see whole of the skeleton is showing a vid uptake, and you can see it is a beautiful looking scan. This is basically a super scan. You can see and this axial skeleton is showing much higher uptake as compared to appendicular skeleton, and there is almost negligible soft tissue visualization, and also kidneys are almost not visualized. So these three features again favor super scan. This super scan basically in two kind of lesions, like one is extensive metastasis, another in metabolic bone disorder. And as you know, the case is discussing, this is goes more in favor of metabolic bone disorder. Yes, Dr. Sudhi?
So, since as Dr. Annie mentioned, the patient had had a bilateral paratracheal lesions. We were not able to differentiate whether those are separate from the main thyroid mass or are part of our intrathyroidal, maybe partially. So the right nodular lesion was not looking good. It was looking highly suspicious for malignancy. So we also, and the patient has a case of a hyperparathyroidism. So we found it more useful to rule out medullary thyroid cancer in such case. So we had a screening calcitonin, which was within normal limit. And we also had a FNAC of the right thyroidal lesion, intrathyroidal lesion, and which was benign follicular nodule with toxic changes. Okay, so pre-operatively, we had a provisional diagnosis of polycystic kidney disease, which were visualized on ultrasound. It was a polycystic kidney as well, with renal bone disease, tertiary hyperparathyroidism with hypercalcemia, with chronic kidney disease, and with hypertension stage 4. So he was started, apart from dialysis, on calcitonin, sinacalcate, zoledronic acid, and thiazides to decrease the serum calcium level, to have a control over it. And with all these maneuvers and with guarded hydration, we were able to bring his calcium from 14 to 15 till 11 milligram per deciliter, which was still high. So we knew that the patient requires surgery. So we prepared the patient for surgery. So as a surgeon, as an endocrine surgeon, my provisional diagnosis was tertiary hyperparathyroidism with chronic renal failure, with metabolic bone disease, with recurrent nephrolithoties, with toxic nodular goiter. So I was not sure because his TSH was suppressed. So most probably it was from some thyroid nodule only. And we did not have the thyroid scan done to rule out this because of some financial issues. And also we just, because of the kidney condition, wanted to avoid any more contrast. And we were not sure whether we are dealing with malignancy or not. We just thought of doing total thyroidectomy and to explore the neck bilaterally with parathyroidectomy at least. So we operated the patient, and this is the intraoperative cross. And peroperatively, the left superior parathyroid we did not see, but the remaining parathyroids were normal looking, and they were not looking even hyperplastic. So we left those parathyroids, and we just did the total thyroidectomy. And as I was expecting, the lower pole of the thyroid was intrathoracic, but fortunately we were able to deliver it cervically. The cut section showed a heterogeneous mass lesion involving the lower pole of the thyroid. The superior pole of the thyroid was fleshy and normal looking. This was not looking good on cross examination. Not looking good means it was looking more of a malignant lesion. And the left thyroidal lesion, it was part, as you have seen, it was partially intrathyroidal. So, but that nodular lesion was soft, and with cystic changes were there, and it was well encapsulated. and the field was looking good, at least on upfront gross examination. The thyroid was, normal thyroid was also appreciated, and which was the lower and the medial part of the lesion, in the lower and middle part of the lesion. So post-operatively, he had hungry bone syndrome, which was managed with intravenous calcium and intravenous as well as oral IV, oral calcium supplements and vitamins. He had an unrelated condition of bleeding hemorrhoids leading to anemia, for which he had a laser population. And histopathology, I request Dr. Chani to describe. And there were some very surprising features we found in histopathology, and I request her to describe those findings.
Ma'am, next slide, please. That will be the next one. So on histopathology gross examination, total thyroidectomy specimen was received and weight was 150 grams and size was 11 by 10 by 10 centimeters. Right lobe was 10 into 5 into 5 centimeters and left lobe was 7 by 6 by 4 centimeters. Cut surface of right lobe showed multiple nodules with glistening surface and left lobe showed gray-white solid cut surface. Next, ma'am. On microscopy of the left lobe, as we can see here on the left side image, it was an encapsulated tumor. The pink, this pinkish portion is the capsule and the blue area is the tumor. And on Hyper, the arrangement of the tumor was in sheets, microfollicles, these small follicles and macrofollicles. Next, ma'am. Next. Most of the tumor was composed of uniform cells. As we can see here, there's not much variation in size, and even dispersed chromatin was there, round regular nuclei were there. But in some areas, we saw mild to moderate atypia with pleomorphism and multinucleation, as well as some bizarre cells were also seen. Now, as we studied the capsule and the vessels, now some of these blood-filled spaces with attached tumor emboli or portions of tumor cells were seen at multiple places in the capsule. So were these vascular spaces? And at multiple places, in the capsule perpendicularly oriented nodules of tumor tissue were also seen, as can be seen in this image also. So multiple nodules in the although they were not fully transgressing the capsules, they were limited within it, but they were perpendicularly oriented with the main tumor. The right lobe showed features of multinodular goiter with variable sized thyroid follicles filled with colloid. So on histopathology, the right lobe was multinodular goiter and left lobe was a parathyroid tumor with the differential diagnosis of adenoma or a carcinoma. So we went for immunohistochemistry. And in immunohistochemistry, the parathyroid origin was confirmed as the tumor was positive for pan-CK, chromogranin, and GATA3. And thyroid origin was ruled out as it was negative for thyroid markers, TTF1 and thyroglobulin. Moreover, it was positive for BCL2, which the expression of BCL2 is usually lost in carcinomas. So BCL2 immunoreactivity indicated a benign tumor. And Ki67 index was also 2 to 3%. So this also favored a benign entity. Then the spaces, blood-filled spaces, were pseudovascular spaces, and because they didn't show lining by endothelial cells, as shown by absence of D240, which is a marker for lymphatics, and CD34, which is a marker for vascular lining. Next, ma'am. So our final diagnosis was parathyroid adenoma.
Okay, so this IHC report gave us some relief that the patient is not suffering with malignancy, but anyhow, unfortunately, the patient was lost to follow-up for quite a long time. And because of in order to present this, because of this presentation only, when we contacted the patient, to a pleasant surprise, not only the patient was alive, but he was symptomatically much improved. So when we recently met him, his bony pains, bony weakness, bony swelling, food, everything was much improved. His food intake was also improved. He gained around 7 kgs of weight in last 1 year. And his urine output, which was almost nil at the time when we operated him, now whatsoever volume of fluid that he consumes, at least that much amount of urine he is able to pass. And his dialysis frequency has also come down from twice weekly to once in a fortnight. So हफ्ते में 2 बार जो होती थी, अभी 2 हफ्ते में 1 बार हो गई उसकी. His biochemical examination showed up some mixed results. His hemoglobin has improved, but his urea creatinine, this creatinine has deteriorated, though urea showed some improvement. And his most probably he was taking his thyroxine replacement therapy irregularly. His TSH was very much raised, and alkaline phosphatase was also reduced. Random blood sugar was normal. His inorganic phosphorus, which was very high at that time, was within normal range, and his ionized calcium is also within normal. It was slightly lower, on a lower side, which is what is expected in a patient like him. His IPTH was also in a normal range, normal reference range, with a normal sufficient 25 hydroxy vitamin D. So the reports were very reassuring. The follow-up was very reassuring to us. So if we compare his bony swelling, which was very prominent before surgery, has also become less prominent on either side, both the sides. This was the pre-op, and this is the post-op, current images. The X-ray also we tried to compare. This was the pre-op image, which it was more sclerosed, more radiodense compared to the current one, which is relatively radiolucent compared to the one which we did in a pre-op period. And this is now how the patient is right now. And now, so why we chose this case to be discussed in this forum? Because the interplay, the hyperparathyroidism in any patient with chronic renal failure is always a very complicated topic. Through this case discussion, we would like to differentiate between primary, secondary, and tertiary hyperparathyroidism. That is why, and to differentiate, not only that, we would like to see the differences between any benign and a malignant parathyroid tumor. Also, we would like to find out the answer when to suspect hyperparathyroidism in patients with recurrent nephrolithomies, and when to suspect that a patient with a secondary hyperparathyroidism has now progressed to a tertiary hyperparathyroidism, and what difference does it make, and whether the current case is the hyperparathyroidism leading to chronic renal failure, or a chronic renal failure has led to this hyperparathyroidism. So all these things we just want to elaborate from our study, from this meeting. So before going into the detail, first we need to understand what is the normal physiology of parathyroids. So we know that there are 4 parathyroid glands on either side of the neck, posterior to the thyroid gland, and they have a calcium sensing receptors on their cell membrane, and a channel through which they release the parathyroid hormone. This parathyroid hormone, हम कह सकते हैं कि the main aim of this parathyroid hormone is to increase the blood calcium level. Blood की calcium level को बढ़ाना होता है through different means, like in the bone it increases the osteoclastic and osteoblastic activity. वहाँ से जो calcium है, it is leached into the bloodstream, so increases the blood calcium level. Secondly, it increases the vitamin D. It helps in the activation of the vitamin D, which helps in the absorption of calcium and phosphates from the intestine. Whatsoever food we take, it helps in the absorption of calcium and phosphate. And thirdly, it stimulates the renal tubules to reabsorb the excreted calcium into the urine. So जो excreted calcium होता है उसको ये reabsorb कराता है. Now, when these calcium sensing receptors, whenever calcium molecules are attached more than a limit, then it gives a negative feedback to the channel that now no more parathyroid hormone is required. So the more the calcium are attached to these calcium sensing receptors, the more inhibition of parathyroid hormone release happens. But whenever there is any abnormality in any parathyroid gland, these calcium sensing receptors, they get mutated. So initially, if they were tuned to receive sense, they are वो इस तरह से tuned up होते हैं कि उनका जो calcium है वो 9 to 11 की range में रहे. Now their range is increased, 11, 12, 15. It could be anything. And till the time that calcium level is, blood calcium level is reached, they keep on secreting parathyroid hormone. Okay, so जो parathyroid hormone है वो बढ़ता रहता है. In that process, those abnormal cells keep on proliferating, whereas this high calcium level, they decrease the or they inactivate the normal parathyroid cells. जो normal parathyroid cells है वो suppress होती रहती है, और जो abnormal cell है क्योंकि उनका target blood level अभी तक achieve नहीं हुआ, they keep on multiplying, and gradually with due course in time, they occupy most of the parathyroid gland. So these are the normal parathyroid cells, and they are inactivated, whereas the जो abnormal cells है, they keep on secreting the parathyroid hormone. So what this increased parathyroid hormone do? Now this uncontrolled secretion of parathyroid hormone, they keep on increasing the blood calcium level to meet the demand, and in that process they continuously leach the bones. जो bones है उससे continuous जो decalcification है, it continues, so that gradually the bone become weak. Secondly, they decrease because parathyroid hormone increase the reabsorption of calcium from the renal tubules. That process is increased, but in blood, the level of blood calcium is so much that it supersaturates, and this supersaturated calcium now is secreted into the renal tubules, and the urine is supersaturated with calcium. Therefore, it crystallizes with each other, and gradually first they form some powdery deposits in the form of nephrocalcinosis, and these small powdery deposits then attach further and they form small renal stones leading to some large renal stones. They could be multiple, they could be solitary, could be anything. And whenever these renal stones, they are impacted into the collecting tubules, collecting system, then they may cause hydronephrosis and may damage the kidney. Otherwise also they may lead to urinary infection and keep on damaging the kidneys. Other than that, this high calcium, because we know calcium is very vital for nervous neurotransmission. So with this abnormality, the patient, these type of patient, they feel fatigue, memory loss, poor concentration, anxiety, because there's an abnormality in neural transmission in these patients. And also these patients develop muscle wasting, because we know that neurotransmission is also helpful in keeping the muscle stout and healthy. This hypercalcemia leads to dyspepsia and constipation. This conduction abnormality because of hypercalcemia also affects the heart. The pumping activity of the heart is affected. The heart gradually becomes more weak. The coronaries and the other arteries, they get atherosclerosed. The patient develops hypertension. This hypercalcemia leads to abnormal deposition in the pancreas. They cause acute pancreatitis. It could be life-threatening, and it happens. It is seen in patients very frequently. And when these metastatic deposits occur in the soft tissues, they may cause from itching to ulcers to even necrosis of the limbs. So this overall, if we see, any untreated parathyroid disease may decrease the life expectancy by 5 to 6 years. And not only these disorders, they happen, these patients become more prone to develop malignancies like colon, kidney, breast, and prostate. So the association is very frequently that we see in such patients. So what is the cure? We must know that medication will not cure parathyroid diseases. Most of the diseases of parathyroid, they are cured only by surgery. So now, if we come specifically, now that we know what is the basic pathophysiology of parathyroids, now if we come specifically to understand what is primary, secondary, and tertiary hyperparathyroidism, it is very simple. If we simplify this complex procedure, we must understand that there are only 4 organs that are involved in this pathophysiology: the parathyroid glands per se, kidneys, intestine, and bones. Okay, and there are 5 to 6 chemicals, biochemicals, which are involved. So everything, it is the interplay of all these organs in biochemistry that happens in all different types of parathyroid disorders. This is calcium, either total and ionized. Ionized is more important for us. Inorganic phosphorus or phosphates, vitamin D, IPTH. Okay, so and creatinine. So what happens in primary hyperparathyroidism? The pathology starts with the parathyroid gland. So a parathyroid gland, due to any mutation, could be adenoma, is found in most of the time, 85%. Then due to multiple adenomas, carcinoma, or MEN type 1 or type 2, due to mutations, any of the parathyroid gland becomes abnormal and they start secreting the parathyroid hormone in an abnormal way. So this increased parathyroid hormone then stimulates the kidney to increase the calcium, to increase the blood calcium level. But as already told, that this supersaturated blood with calcium, the kidney start excreting the extra calcium and leads to supersaturation of urine with calcium. Okay, means hypersecreting the calcium. And the parathyroid also increases the phosphate excretion. Okay, so this is very important. Parathyroid hormone increases phosphate excretion, and when it is primary hyperparathyroidism, the phosphate excretion will increase through kidneys, and because of vitamin D activation, calcium and phosphates will be absorbed in the intestine, and the osteoclastic activity will increase in the bone. So the kidney will have hypercalciuria. The intestine will absorb more calcium, and the bones will become more weak because of osteoclastic activity. The calcium is removed from the bones. Overall, it leads to increased calcium in the blood. And in biochemistry, apart from hyperparathyroidemia, hyperparathyroid तो blood में बढ़ेगा ही बढ़ेगा, इसके अलावा हमें hypercalcemia मिलेगा और hypophosphatemia मिलेगा. So these 3 things are very important to find out whether we are dealing with primary or secondary or tertiary maybe. So hypophosphatemia is very important. And why? ये अभी हम आगे बात करेंगे. Primary hyperparathyroidism is surgery only. Parathyroidectomy. There is no medical cure of this condition. जब तक ये ट्यूमर हम निकालेंगे नहीं, patient is not going to get cured of this condition. अब now comes the secondary. अब secondary में क्या होता है? Secondary में तो parathyroids are normal, but either because of deficiency of vitamin D, या फिर there is some chronic renal failure, there is decrease in calcium due to any condition. If the blood calcium level is low, अब ये blood calcium level low कैसे होगा? या तो वो absorb नहीं हो रहा होगा intestine से, either because of low calcium intake, or there is a deficiency of vitamin D, because of which whatsoever calcium we are ingesting वो intestine में absorb नहीं हो पाएगा, इसलिए blood में calcium का level कम हो जाएगा, and it will stimulate the parathyroid gland. Other than that, जो दूसरा common condition है, that is chronic renal failure. So what happens in chronic renal failure? अब renal tubules का जो function है वो कम हो गया because of the disease of the kidney. So the kidney is not able to reabsorb the calcium, excreted calcium. Also, the kidney is not able to excrete the phosphorus. उसको वो excrete नहीं कर पा रही है. और thirdly, वो vitamin D को synthesize नहीं कर पा रही. इसकी वजह से भी जो इंटेस्टाइन से कैल्शियम का एब्जॉर्प्शन है वो कम हो जाएगा. एंड सेकेंडली, ये जैसे बताया है कि विटामिन डी की डेफिशिएंसी की वजह से ना फास्फोरस और ना ही कैल्शियम इंटेस्टाइन एब्जॉर्ब कर पाते हैं. ओवरऑल क्या होगा? देयर विल बी हाइपोकैल्सीमिया, कैल्शियम का लेवल कम होगा, एंड हाइपरफॉस्फेटेमिया, फॉस्फेट का लेवल अनयूजुअली हाई होगा. एंड दोनों ही फैक्टर्स स्टिमुलेट करेंगे नॉर्मल पैराथायराइड। पैराथायराइड अपरेंटली आर नॉर्मल, लेकिन बिकॉज उनका जो स्टिमुलेटिंग फैक्टर है वो अभी काम कर रहा है, इसलिए ऑल द पैराथायराइड्स दे गेट hyperplastic. अब these hyperplastic parathyroid glands they secrete parathyroid hormone, जो कि नॉर्मल से लेवल बड़ा होगा, बट लाइक उनका स्टिमुलेटिंग फैक्टर एज वी हैव डिस्कस्ड कि कैल्शियम उनको स्टिमुलेट किया जा रहा है, हाइपोकैल्सियम और हाइपरफॉस्फेटेमिया. एंड दिस हाइपरपैराथायराइडिज्म विल क्रिएट द मेटाबॉलिक बोन डिजीज. इसका जो इफेक्ट होगा वो मेटाबॉलिक बोन डिजीज की तरह प्रेजेंट करेगा. पैथोलॉजिकल फ्रैक्चर्स हो सकते हैं, पेन्स हो सकते हैं. When we will do the biochemistry of such patient, there will be hyperparathyroidism, parathyroid hormone will be high, hypocalcemia और normocalcemia. हो सकता है पैराथायराइड हार्मोन इतना बढ़ गया हो कि उसमें बोन से कैल्शियम लेवल नॉर्मल रेंज में आ गया हो, बट इट इज बिकॉज ऑफ इंक्रीज पैराथायराइड हार्मोन. सो दीस पेशेंट हैव hypo or normocalcemia, but hyperphosphatemia. So this is the characteristic. These patients have hyperphosphatemia. So the treatment is, it is a medical condition because the parathyroids are normal. Therefore, we don't need to do anything regarding parathyroid except for that we should supplement the patient with vitamin D and to manage the chronic renal failure as what are the protocols. But now comes the tertiary hyperparathyroidism. So this persistent stimulation in the form of hyperphosphatemia and hypocalcemia, फॉस्फेट बड़ा होना और कैल्शियम की कम होने से जो स्टिमुलेशन हो रहा है, जब वो लंबे समय तक, लंबे ड्यूरेशन तक चलता रहेगा, अनअपोज चलता रहेगा, एक सर्टेन टाइम आता है जब वन और मोर ऑफ द पैराथायराइड दे बिकम ऑटोनॉमस. इतने स्टिमुलेशन के बाद अब वो ऑटोनॉमस हो गए. ऑटोनॉमस मींस दे स्टार्ट सिक्रीटिंग मोर एंड मोर ऑफ पैराथायराइड हार्मोन. So this parathyroid hormone is, the levels are much more than the usual primary hyperparathyroidism cases. So what this hyperparathyroidemia do, ये इंटेस्टाइन से कैल्शियम और फॉस्फेट का एब्जॉर्प्शन बढ़ाएगा. किडनीज क्योंकि ऑलरेडी डैमेज्ड है, माइंड इट, ये जो हमारा सेकेंडरी हाइपरपैरा था वही अब टर्शियरी बन गया है, तो किडनी की कंडीशन इसमें चेंज नहीं होगी. किडनी अभी भी डैमेज ही है, डिजीज ही है, इसलिए ये ना कैल्शियम को रीअब्सॉर्ब करेगी ना ही फॉस्फेट को एब्सॉर्ब करेगी. एंड बिकॉज दिस पैराथायराइड हार्मोन इज very high, it increases the bone resorption and osteoporosis, and such metabolic bone disease is a very severe disease. So biochemistry में, as like in other cases, we will get hyperparathyroidism. पैराथायराइड का हार्मोन का लेवल बढ़ा होगा, लेकिन ये बहुत ही अनयूजुअली हाई होगा. इसके अलावा देयर विल बी हाइपरकैल्सीमिया. तो जो सेकेंडरी में हाइपोकैल्सीमिया मिल रहा था, अब हमें हाइपरकैल्सीमिया मिलने लगी. तो क्यों? क्योंकि इंटेस्टाइन से कैल्शियम का एब्जॉर्प्शन बढ़ गया और बोन से इनसे कैल्शियम का, बोन का रिजॉर्प्शन बढ़ गया, इसलिए अब जो हाइपो था अब हाइपरकैल्सीमिया हो गया. लेकिन द हाइपरफॉस्फेटेमिया विल रिमेन द सेम बिकॉज द किडनी फंक्शंस आर नॉट एट ऑल इम्प्रूव्ड. इनफैक्ट इन सारे प्रोसेसेस के बाद किडनी फंक्शन और ज्यादा डिट्यूरेट होगा. तो जो थोड़ा बहुत भी फॉस्फेट एक्सक्रीट कर रहा था, तो अब वो फॉस्फेट एक्सक्रीशन भी उसका कम हो जाएगा. सो व्हाट इज द ट्रीटमेंट? ट्रीटमेंट इज one and only, that is parathyroidectomy. So in such cases, in tertiary hyperparathyroidism, we do either 3.5 gland parathyroidectomy or we remove all the 4 and we auto transplant the most normal looking parathyroid gland in the non-dominant forearm muscle. So now अगर हम इन सारी चीजों को कंपेयर करें, तो जैसा अभी हमने डिस्कस किया कि जो पैराथायराइड हार्मोन है ब्लड में, वो सारी कंडीशन में बड़ा होगा, लेकिन टर्शियरी में ये अनयूजुअली हाई रेंज होगा. कैल्शियम प्राइमरी और टर्शियरी में बड़ा होगा, सेकेंडरी में ये नॉर्मल या कम होगा. फॉस्फेट्स रीनल कंडीशन में हमेशा बड़े रहेंगे, प्राइमरी में ये कम होंगे या नॉर्मल होगा. विटामिन डी कुछ भी हो सकता है, नॉर्मल हो सकता है, कम हो सकता है. सेकेंडरी में यूजुअली कम होता है और हमें बाहर से ज्यादा सप्लीमेंट करना पड़ता है. अब अगर हम इसको अपने केस के साथ कोरिलेट करें, सो वी नो कि हमारा पैराथायराइड मोर देन 20 टाइम्स अबव द अपर नॉर्मल लिमिट था. हमारा जो कैल्शियम था ये बढ़ा हुआ था, हमारा फॉस्फेट प्री ऑपरेटिव फॉस्फेट बढ़ा हुआ था और हमारे पेशेंट को एंड स्टेज रीनल डिजीज थी. तो we can understand that we were dealing with a tertiary patient with a tertiary hyperparathyroidism. So whether the current cases, हमारा दूसरा क्वेश्चन है कि is it hyperparathyroidism leading to chronic renal failure या chronic renal failure leading to hyperparathyroidism? तो यहाँ एक disclaimer है कि we do not have any prior investigation, so it is very difficult to comment. But there are some supporting evidence, like this patient had a long history of recurrent nephrolithotomies as initial symptom. So this could be a point, and associated here the past history of pathological fracture in 2010. So these 2 points may guide कि most probably this patient was having primary hyperparathyroidism which was overlooked and which lead to the chronic renal failure. And this chronic renal failure now again because of persistent secondary hyperpara because of chronic renal failure, now the patient has a mixed pictures of tertiary hyperparathyroidism and primary hyperparathyroidism. And also when we operated, we found that other parathyroids were apparently normal. Those were not even hyperplastic. So these were the points in favor of this thing. The other point, is it a chronic renal failure leading to hyperparathyroidism? So because this patient presented to us as a case of a chronic renal failure as an initial presentation requiring dialysis, so most probably it could be a cause, but like as a disclaimer said, it is difficult to comment at present. Now, when to suspect hyperparathyroidism patient with recurrent nephrolithosis? Once there was a time, एक समय था जब ये माना जाता था कि जो hyperparathyroidism है ये बहुत ही रेयर डिजीज होती है. लेकिन आज के समय में जब से स्क्रीनिंग कैल्शियम शुरू हुआ है, we know कि it is not that rare. It is a very frequently occurring hormonal disorder. But the thing is, because the people don't know about it, it is most of the time overlooked. So it has been suggested any patient with recurrent nephrolithosis, if that patient has musculoskeletal problem like osteoporosis, metabolic bone disease due to any reason, उसको GI symptoms हो, उसको pathological fracture की history हो, उसको bony deformities हो, उसकी shortening of height की history दे रहा हो, बड़ा ही cachectic look है अगर patient का, या अगर patient को chronic dyspepsia की complaint है, chronic constipation की complaint है, peptic ulcer disease है, या acute pancreatitis की history है, या patient को neurological और psychiatric disorders है, जैसे memory impairment, depression, एंजाइटी, कंफ्यूजन, इस तरह की कोई भी प्रॉब्लम है, कार्डियोवास्कुलर अगर उसको हाइपरटेंशन है या कार्डियक प्रॉब्लम है, तो इट इज ऑलवेज गुड टू रूल आउट प्राइमरी हाइपरपैराथायरॉइडिज्म इन सच केसेस. एंड वेरी सिंपल बायोकेमिकल टेस्ट दैट वी यूज टू फाइंड आउट is serum calcium total and ionized. Why ionized? Because the total calcium is dependent on serum albumin and protein level. So many factors affect. Ionized is more specific. Inorganic phosphorus, alkaline phosphatase, creatinine, and vitamin D, and intact PTH. So this intact PTH is also very important. So the thing is, this small biochemical examination can very well find out whether we are dealing with a primary hyperparathyroidism, because this condition is completely curable. So we can save the patient from the later complications. Now, कब सस्पेक्ट करना चाहिए कि जो सेकेंडरी हाइपरपैराथायरॉइडिज्म है, नाउ इट इज transforming to tertiary hyperparathyroidism, because the management is totally different in these two conditions. Secondary, the management is medical, and tertiary, the management is surgical. So the important is, whenever there's an unusual progressive rise in IPTH, तो अगर IPTH में अब बहुत ही अनयूजुअल राइज हो रहा है, जो पहले सपोज 300 400 था, अभी 1000 1500 2000 पहुंच रहा है, तो इसका मतलब है कि कुछ अंदर चेंजेस आ रहे हैं पेशेंट के. और अ पेशेंट विथ हाइपोकैल्सीमिया इज नाउ कन्वर्टिंग इनटू हाइपरकैल्सीमिया विदाउट एनी कैल्शियम सप्लीमेंट. The patient has now developed intense generalized itching, superficial skin ulcers due to calciphylaxis. Patient developed bony deformities, bony pains, pathological fractures. There's a progressive decline in renal function, and there is a localizable parathyroid lesion. Then suspect tertiary hyperparathyroidism and get ready for surgery, because one can very well help the patient by removing the autonomous parathyroid. Now, how to differentiate between benign versus malignant parathyroid lesion? These are the clinical comparison that I am going to give. So, parathyroid carcinoma and tertiary hyperparathyroidism. इसमें कॉमन फैक्टर्स क्या क्या है? एक तो है दोनों का ही स्टॉर्मी कोर्स होता है, दोनों में ही अनयूजुअली हाई आईपीटीएच मिलेगा, दोनों में ही मैलिग्नेंट हाइपरकैल्सीमिया मिलेगा. मैलिग्नेंट मींस कैल्शियम इन द रेंज ऑफ 14, 15 में भी 16 ऐसा मिल सकता है. सीवियर मेटाबॉलिक बोन डिजीज होगी, वेस्टेड पेशेंट लगेगा, बहुत ही कैकेक्टिक लुक होगा ऐसे पेशेंट्स का. और मेनी टाइम्स दे हैव acute pancreatitis because of such an high serum calcium level. बट डिफरेंशिएटिंग पॉइंट्स हैं कि पैराथायराइड कार्सिनोमा एक प्राइमरी डिजीज, प्राइमरी पैथोलॉजी ऑफ पैराथायराइड है. इट इज अ प्राइमरी हाइपरपैराथायरॉइडिज्म. इसमें किडनीज नॉर्मल होंगी, इसलिए फॉस्फेट लो या नॉर्मल होगा. अब क्लिनिकल और इमेजिंग फीचर्स ऑफ मैलिग्नेंट लीजन मिलेगा हमें फील करने में भी हो सकता है काफी सस्पिशियस, क्योंकि ये बहुत ही हाईली एग्रेसिव ट्यूमर्स होते हैं और हो सकता है अल्ट्रासाउंड में हमें इनकी लुक बहुत ही मैलिग्नेंट टाइप. इसके अलावा अदर parathyroids will be either normal or suppressed. The disease-free survival and overall survival without definitive surgery is very low. अगर हम कोई definitive surgery या उसके आगे का definitive treatment नहीं करते हैं तो survival बहुत low होता है, overall survival and disease-free survival. Whereas tertiary hyperparathyroidism में tertiary problem, मतलब parathyroids normal थे, उनको continuous stimulation देने के बाद वो जाके abnormal बने. इसमें जो किडनीज होती है यूजुअली एंड स्टेज रीनल डिजीज होता है, फॉस्फेट्स अनयूजुअली हाई मिलेंगे, क्लिनिकल एंड इमेजिंग फीचर्स ऑफ बिनाइन लुकिंग लंप होगा, अदर पैराथायराइड्स हाइपरप्लास्टिक होंगे, एंड ओवरऑल सर्वाइवल एंड डिजीज फ्री सर्वाइवल विल डिपेंड अपॉन द रीनल स्टेटस के ऊपर डिपेंड करेगा. नाउ आई रिक्वेस्ट डॉक्टर चानी टू गिव अस सम हिस्टोलॉजिकल इंसाइट ऑफ सच लीजन.
I'll be giving just a brief overall regarding pathology of parathyroid gland. So first we'll see the normal histology. Now there are 4 glands in 2 pairs, usually close to upper and lower poles of thyroid lobe. Grossly, they are yellow-brown in color, 25 to 40 milligram each gland. If we can see the photograph here, the one encircled is a normal parathyroid gland, which can be easily confused with a lymph node if we see it grossly. On histology, the parathyroid gland is composed of primarily chief cells along with fat with thin fibrous capsule dividing gland into lobules. So if we see the photomicrograph, we can see the blue areas which are the parenchyma and intermingled stromal fat. Other cells which are found are oxyphil cells and water clear cells. Oxyphil cells are pink in color and water clear cells have a clear cytoplasm. Next, ma'am. The most important 3 entities in parathyroid pathology are parathyroid hyperplasia, parathyroid adenoma, and parathyroid carcinoma. So clinical association, first we will see parathyroid hyperplasia. It can be found in primary hyperparathyroidism, but as per the new fascicle of WHO 2022, no genetic predisposition is important in cases of primary hyperparathyroidism. That is, when earlier in men 1, men 2A, we used to classify the lesions as parathyroid hyperplasia because it was a multiglandular involvement. But after clonal studies, they have come to the conclusion that they are actually multiglandular adenomas. Then secondary hyperparathyroidism and tertiary hyperparathyroidism. In case of parathyroid adenoma, 85% of primary hyperparathyroidism are because of parathyroid adenoma. Then in cases of tertiary hyperparathyroidism also, it can be due to a parathyroid adenoma, as was in our case. Then genetic syndromes like MEN1, MEN2A, MEN4, and HPT-JT, which is hyperparathyroidism, jaw tumor syndrome. Inferior glands are more involved than the superior ones. Inferior parathyroid adenomas may be intrathyroidal, and 15% double adenomas can also be seen. Then parathyroid carcinoma, it is a very rare entity and it constitutes less than 1% of primary hyperparathyroidism. It is even rarer in cases of tertiary hyperparathyroidism and is associated with high PTH levels, which can be 3 to 10 times upper limit. So there are, to avoid confusion, we should strictly follow the WHO diagnostic criteria, which has been provided for each of these entities. So essential criteria for hyperplasia is involvement of more than one parathyroid gland, and desirable is presence of a known disorder to cause secondary or tertiary hyperparathyroidism. In case of adenoma, enlarged cellular gland consisting of benign parathyroid proliferation and often surrounded by a rim of atrophic parathyroid parenchyma, which is a very important feature to differentiate it from hyperplasia. And carcinoma, it has to have one of the following features: angioinvasion, lymphatic invasion, perineural invasion, or local invasion into adjacent structures or organs like soft tissue or thyroid, and or histologically confirmed metastasis. Any one of the following feature has to be present to label it as a carcinoma. And the desirable criteria for carcinoma is ancillary biomarkers like Ki67, where shows the proliferation index more than 5%. Parafibromin and galectin-3 immunohistochemistry is helpful, as we will further see. Next, ma'am. If we see on histopathology, in hyperplasia, there will be hyperplasia of chief cells with intermixed adipocytes. However, there is increase in parenchymal cells as compared to stromal fat. Here we can see stromal fat is present, but it is much depleted as compared to a normal gland. In case of an adenoma, a thin pseudocapsule will separate the adenoma from the normal gland, and no adipocytes and adjacent compressed normal parathyroid are key features for diagnosing an adenoma. If we see in this image, the lower half is showing the adenoma where only parenchymal cells are there and no fat is there. And in the upper half, the adjacent normal parathyroid is visible with both stromal fat and the parenchyma. And parathyroid carcinoma must show frank invasion into adjacent tissue, angioinvasion, lymphatic invasion, or perineural invasion. If we see this image, we can see a satellite nodule. This is the main tumor, and a nodule can be seen in the adjacent soft tissue. So there is clear-cut evidence of invasion. So treatment of hyperplasia is surgical, and then is surgical, where the surgeons will be better be informing us about it. But what literature says is 3.5 out of 4 glands, and same with adenoma and parathyroid carcinoma will be as per the staging. The surgical intervention will be done. Now, prognosis in case of hyperplasia, the prognosis depends on the underlying disease, that is the stimulus which is leading to secondary or tertiary hyperparathyroidism like CRF. In cases of adenoma, prognosis is good. After surgical removal, recurrence rate is less than 2%. And in multiglandular disease, depends on underlying disorder, that is the underlying genetic disorder. In carcinoma, the prognosis is multifactorial. It will depend on the locoregional metastasis. Incidence is 25 to 60%, and late distant metastasis is 40%. Next, ma'am. Immunohistochemistry, if we have to differentiate of adenoma and a carcinoma, so adenomas will be positive for PTH and GATA3 and neuroendocrine markers, chromogranin A and synaptophysin. These markers basically confirm the parathyroid origin, and parafibromin expression is seen. Parafibromin is important because there will be a loss of expression of parafibromin in parathyroid carcinoma. And thyroglobulin and TTF1, PAX8, all are thyroid origin markers. These all will be negative in a adenoma. In carcinoma, there is loss of expression of certain markers like parafibromin, APC, E-cadherin, P27, BCL2, MDM2, etc. In our case also, BCL2 was expressed, and which favored the diagnosis of adenoma as compared to a carcinoma. And there are various battery of markers for positive overexpression also, along with increased Ki67, which is important, and it is often more than 5%, which in our case was only 2 to 3%.
Okay, So I hope we were able to present a reasonable literature review and is able to simplify the things. These things are very, very complicated, I understand, but I hope we were able to put our points here. I request Anand sir, Gyan sir to give their expert comment about our case, about our management, and what do they feel if such type of patient would have presented in their institute, what could be their management protocol or algorithm in such type of case.
Thank you, Sudhi. This case was wonderfully managed, and in fact, I was so much involved in your case, and after case discussion, the theoretical part, that I enjoyed your presentation and your explanation of various things, and it was very well managed. It was a very difficult case, and if you ask my opinion, overall opinion after listening to the case and management, so you have already explained that. So I think it is a case of parathyroid carcinoma. If you see for the audience, I mean the listeners, in the secondary hyperpara, the main problem is of phosphate metabolism, and there is CKD, there is vitamin D deficiency, and then phosphate metabolism that complicates everything. In primary, there is a problem starts from the parathyroid gland. Okay. So in this case, since it is a parathyroid carcinoma finally, and since past history of nephrocath, history of kidney stones, history of fractures 10 years back, so I take it that way that although in secondary also we see a parathyroid carcinoma, it has been reported in literature. So I see it as a parathyroid problem from the beginning, which caused high calcium level, which resulted probably in CRF, and then the patient has all this problem. And surgical part, because it is a surgical disease, parathyroid is a surgical disease, you have managed this very well, you have done a good surgery, no complication, nothing. And these surgeries are for everybody, these surgeries are very difficult in these patients, and especially in CRF patients. A total thyroidectomy is a difficult situation because these patients have platelet dysfunction. There is a risk of hemorrhage during the surgery, and post-op there is a problem, issues in these patients. These are not straightforward surgeries. Any surgery in CRF patient is not a straightforward surgery. And in that patient, a total thyroidectomy without complication, I will congratulate you. And then, so my impression is it's a parathyroid carcinoma. Probably this patient has a problem from the beginning, and these end organ damages started because this problem was not identified or picked up earlier. And that's the way I think. And thank you. I thank you for making this, presenting this, and sharing this type of case, making a forum of endocrine breast in your area, and then managing these difficult cases, and then coming out to discuss this case among your colleagues and keeping me as an expert. Thank you, Sudhir.
So thank you for your expert comment. The thing is that actually Dr. Chani presented her impression of the slides. Why I said कि जो histopathology was very interesting, because the histopathology first went to some other center where they crossed it and they reported as parathyroid carcinoma. She shown us the images, but we were not sure. Sir, now please give us your expert comment. This patient had a problem since 2009. तो अगर हम समझते हैं कि इनको पैराथायराइड कार्सिनोमा रहा होगा, तो डू यू थिंक कि ये इस तरह का कोर्स हो सकता है पैराथायराइड कार्सिनोमा में? और दूसरा, अब जैसे ऑपरेशन के बाद, ऑपरेशन में हमने लिम्फ नोड डिसेक्शन नहीं किया था, जैसे यूजुअली हम करते हैं, साइड का थायराइड निकालते हैं या टोटल थायराइड में लिम्फ नोड डिसेक्शन. We did not do any such surgery in this case, and still now after 1 year the parathyroid hormone is within normal range. So should we consider this case as a parathyroid carcinoma, or should we अब हम थोड़ा सा relax हो सकते हैं कि अच्छा अभी 1 साल तक patient ठीक है, तो अभी हमारे लिए relatively better condition है और शायद ये patient को आगे भी कोई problem ना हो. तो is it right to say कि parathyroid carcinoma है इस patient को?
Okay, so there are two things. First question is that you still not very sure about parathyroid carcinoma. Now, if you differentiate between an adenoma and carcinoma.
Yes, sir.
Carcinoma patients have very high calcium.
Yes,
Carcinoma patients have very high PTH. In carcinoma patients, the disease is palpable clinically. And the fourth thing, these patients have usually both bone and kidney disease. If you just see the difference between a carcinoma and adenoma. And in your patient, these all four things were present, if I say. Now, next issue is about surgery. So for carcinoma, composite surgery is enough. You have done a total thyroidectomy because that patient had on other side a nodule, and on left side this was whole mass, and that surgery. So for carcinoma, a parathyroid lesion along with hemithyroidectomy is sufficient. There is no need for any central lymph node dissection or lateral lymph node dissection. And in your patient, since there were no lymph nodes, so your surgery is complete. Now, only in rare situation when there are lymph nodes, then only lymph node dissection is indicated. Otherwise, there is no role of any prophylactic lymph node dissection or berry picking or going for lymph node dissection. So, second thing, you have done a complete surgery if it was a parathyroid carcinoma. Still, I feel, because on clinical grounds, I feel it is a parathyroid carcinoma. On natural history, I feel it is a parathyroid carcinoma, because in secondary hyperpara, the problem is patient has low calcium and high phosphate values. And it's basically secondary hyperpara is a problem of phosphate metabolism. It's not a calcium metabolism. So your patient had high calcium levels. Your patient had a very high PTH level. Patient had a palpable lesion, and then he had both kidney and bone disease. So it's usually you see a combination of these end organs in parathyroid carcinoma. Now the second thing is surgery is complete. Now third question is patient is because these tumors are very slow growing. Parathyroid carcinomas are very slow growing tumors, and rarely they metastasize. They do metastasize to the lung, many organs it has been reported. So they do metastasize, but they are very slow growing tumors. So that also explained the course of the disease in the last 10 years. The course has been progressive. You say a patient had 10 years back the parathyroid disease, fractures and 2 times bone disease, kidney stones. And then the patient finally has gone into the chronic renal disease and on dialysis because of that calcium problem probably. So that's thing. And then your third thing is issue of follow-up. So because it's a parathyroid carcinoma, probably not a part of tertiary hyperparathyroidism, probably part of primary hyperparathyroidism. Patient has bone disease, so you should follow this patient with calcium, with alkaline phosphatase, and with BMD. 6 months, at least yearly BMD. And since patient is on chronic kidney disease, so probably the fate of the patient will be decided by a kidney problem, not because that's end organ damage, not with the parathyroid. If patient develops a recurrence anyway, any place, you can just excise. And since you have done a very good surgery, capsule was not breached, so there is no, I feel there will be no recurrence in the neck. Only problem in the follow-up will be patient may develop a metastasis somewhere.
Thank you, sir. Thank you. May I ask Dr. Neha? Dr. Neha, you have seen the histochemistry profile here.
Yes, sir.
Yeah. So, what do you suggest?
That was a very
yes.
It's a very elaborated case presentation, and thank you for inviting me on this forum. So, can you display the histopathology slides first?
Yes. So these are the histopathology details of the patient. and the other histopathologies that is being recommended to get it done. My question is, what do you suggest? Yeah, this one. Sorry.
Previous one.
Yeah, this is the exact histopathology report of the patient.
This is the immunohistochemistry. Go back to the histopathology.
Histopathology.
3-4 slides पीछे. हाँ.
Yes. मैं शुरू से दिखाती हूँ आपको, है ना, ये ग्रॉस है.
हाँ. हाँ, ठीक है. Okay, next slide.
Yes.
Okay, just focus on this slide. So even the presence of the interspersed large cells, the bizarre cells, or even the focal mitotic figure, like there is a focus of one mitotic figure in this picture. So these all are not suggestive of the parathyroid carcinoma. You may get into the parathyroid adenoma as well as in the parathyroid hyperplasia also. So definitely for the histological criteria of malignancy, the absolute criteria will include the invasion into the surrounding soft tissue, the vital structures, vascular invasion, perineural invasion, or the metastasis. But there are some relative criteria, or there are some features which are associated with malignancy, such as the capsular invasion, high mitotic count, which is reported as a more than 5/10 hyper field, the coagulative tumor necrosis, sheet-like monotonous cells, spindle cells, cellular atypia, diffuse cellular atypia, and the macronucleoli. So these all are the features. There are approximately 7-8 features. And if 4 or more than 4 features are there, then you should suspect the parathyroidism. So now the new entity, not so new, there is one entity, that atypical adenomas. If you found any of the feature, 1 or 2 feature, less than 4 features, which are suggestive of the malignancy, this is called as a atypical adenomas. And it is very difficult to differentiate between the atypical adenomas and the parathyroid carcinomas. Okay. Now go back to the histochemistry.
So what about these features like capsular invasion, vascular, and this perpendicular?
Capsular invasion is just like the we could see in the follicular carcinomas. So there has to be the complete capsular penetration. There has to be the complete capsular breach. It should not be like the mushrooming kind of the projection. Should be the complete infiltration of the capsule. So this is again a feature of malignancy. But you have to be has to be presence of 4 or more of the features which are suggesting malignancy. If there is a presence of any one of the absolute criteria, definitely it is a parathyroid carcinoma. But if you are not getting any absolute criteria, you have to look upon the relative criteria or the features associated with the malignancy. Now, immunohistochemistry may help at times, but if you consider the single immunohistochemistry, like the parathyroid hormone, just confirming the parathyroid tissue. GATA3 is just confirming the parathyroid origin. It is not associated. You may get into the parathyroid hyperplasia adenoma as well as the carcinomas. The other marker which has some importance is a parafibromin. The parathyroid carcinoma showed the loss of the parafibromin. The galectin-3, the tumors are positive for the galectin-3. The cyclin D1, the tumors are positive for the cyclin D1, and the high Ki67 index. So if you're considering the individual marker, the sensitivity and specificity lies between the 70 to 80% and so on. But if you are so I recommend a panel of IHC is better than any single marker and can be used to supplement the diagnosis. So in the panel, you may use the PTH or GATA3 just to confirm the origin, along with the parafibromin, galectin-3, Ki67, cyclin D1. There is one very important marker is the PGP 9.5. What is PGP? PGP is just a phosphoglycoprotein 9.5, which is secreted by the T helper cell 17. So if you are considering the individual marker, PGP 9.5, it has the highest sensitivity as well as a specificity among the all markers like galectin-3, parafibromin and all. There is one large study, original study from our institute, which involves the endosurgery, endocrinology department as well as the pathology department. So we included 227 patients of the parathyroid tumor, which include the adenomas as well as carcinoma and atypical adenomas. So many a times we have atypical adenomas. Around 19 cases are of atypical adenomas and 14 are of the carcinomas. So immunohistochemistry, individual markers are not found sensitive and specific. However, the panel of the immunohistochemistry markers, which include the parafibromin, galectin-3 and PGP 9.5 and high Ki67 index. The 4 markers which are found more sensitive and specific. We have not found any recurrence in atypical adenoma group as well as the parathyroid carcinoma group. So there is some confusion that is it really necessary to discriminate between the adenomas and carcinomas, as we didn't found any recurrence. Just one case showed the recurrence after 2 years.
Okay.
So there is again a question, because surgical management is the same, and after 2 years of follow-up, we didn't find any recurrence. Just one case showed the recurrence. However, there is one significant finding that carcinomatous cells, which are having the predominant oxyphilic cells, oxyphilic with the eosinophilic cells, the oxyphilic cells, those are having poor prognosis. Those patients are showing hypercalcemic crisis. So I think this could be the additional point. You have to look the oncocytic morphology. If there are predominant oncocytic cells, there is a need to follow the patient more vigorously.
Thank you very much. So what it means that in maybe other patients where we find difficulty in differentiating between the adenoma and carcinoma, or maybe there's some suspicion of carcinoma, we must specifically ask our pathologist to get at least fibromin, PGP 9.5 and galectin along with Ki67. Okay, because in this case they did only BCL and Ki67.